All right, so hello and welcome to our presentation that dives into the challenges and unique perspectives of having DMD or Duchenne muscular dystrophy in India. So my name is Sanjana,
My name is Kushal.
and in our project, we wanted to shift our perspective to a topic that we haven't covered in class. And specifically, we chose to focus on the treatment and resources of DMD in India. So moving on to why we chose India specifically. So the first reason is for the healthcare infrastructure. So India has a mix of more advanced medical facilities in urban areas and several deficiencies in rural areas, which can lead to significant disparities in healthcare access. And the second reason is the cultural significance. So in India, cultural beliefs and social norms have a huge impact on the perception and treatment of disabilities. And this stigma can impact those with disabilities, including DMD patients, and can play a huge role in the quality of life for them. And lastly, we chose India for the economic barriers. So the cost of DMD, of treatment for DMD, as we probably all learned in this class, is very high. And when you combine this with the lack of insurance coverage in India, this creates a great financial challenge for many Indian families. And also, both of us are of Indian descent, and for this project, we wanted to present on a topic that we also had a very close personal connection to. So researchers have found that there were greater than 500,000 cases of DMD in India. So given the prevalence of DMD in India, we wanted to cover how the healthcare system there serves these patients. So here is an overview of the topics that we will cover in this presentation. And we will go more into depth with these four topics throughout our presentation, starting with the lack of accessibility. So many healthcare facilities, especially in rural areas, lack the infrastructure needed to adequately support DMD patients. And physical accessibility is a major issue with limited availability of specialized clinics and medical equipment. And the second topic will be lack of insurance. So again, I'm sure we're all aware of the high cost of treatment for DMD by now. So this high cost of treatment combined with the lack of insurance coverage in India creates large financial barriers for many families. And then we will transition into the healthcare disparities that exist across India. And there are a lot of disparities in healthcare between urban and rural areas, which contribute to the differences in the quality of life for DMD patients in India. And we will also cover cultural aspects. So disabilities, including DMD, are heavily stigmatized in Indian society, and this can lead to a lot of social isolation and reduced quality of life for patients. So yeah, we're looking forward to delving more into these, more into depth with these topics in this presentation.
So the first topic that we want to discuss in the context of DMD in India is the lack of accessibility, and this primarily pertains to individuals with DMD who are wheelchair bound, so in the late stages of the illness when they're non-ambulatory. So a report was done by the Center of Research and Planning in India, which examined a variety of public and private buildings, including offices, courts, parks, schools, and other like public transportation stations and things like that. And overall, it revealed a staggering trend, which was the fact that there was a significant lack of accommodations in all of these buildings for individuals with physical disabilities in India. And by accommodations, I mean physical accommodations. So things like elevators or ramps and other things like that that just help individuals in a wheelchair be able to access these buildings and these public places. Now, more specifically, for some statistics, more than half of the district courts in India do not have any ramps. And only 25% of the district courts have been determined to have any form of wheelchair accessibility. So what we see is that a genuine public building, which would be important for individuals to be able to access, whether or not they have ambulation, is actually not very likely for individuals with DMD to have any sort of accessibility for them to access such a building. So now we're going to explore a case study, and this case study is going to explain the patient experience of living with a physical disability in Mumbai. Now, Mumbai is one of India's largest and most populous cities. It has a population of over 20 million people. And we're going to discuss what it is like specifically in Mumbai, culturally, socially, and economically to live with a disability such as DMD. Now, just in general, before we get there, more than 1 billion individuals in the world have some form of disability. And 80% of these 1 billion individuals with some form of disability actually live in a developing country like India. And more than 3% of Mumbai's population lives with a physical disability. And there's some parts of Mumbai's infrastructure and daily life that particularly makes living with a physical disability in Mumbai or any large city in India particularly challenging. Now, this includes busy city streets with severe overcrowding, poor infrastructure funding, and just in general, life in Mumbai, both socially and culturally, for an individual with a physical disability seems exceedingly challenging. And we're going to explore some certain facets of day-to-day life in Mumbai that would not be possible or is very difficult for an individual with a physical disability like DMD. So the first that we want to discuss is the Mumbai public transport. Now, public transport is a very primary mode of transportation for individuals in Mumbai. Commuter trains and buses are substantially used by people as a means of getting around places. And unfortunately, these trains and buses are often overcrowded, very unsanitary, and lack adequate enforcement of accommodations for individuals with disability. And what I mean by this is both the fact that in the stations themselves, there's a widespread lack of elevators, ramps, and other features that allow individuals with disabilities to use them, as well as the fact that the likelihood of reserved compartments, so compartments within trains and buses that are specifically reserved for individuals with disabilities, the likelihood of those compartments being occupied by regular passengers is so shockingly high just due to the fact that these trains and buses are always substantially overcrowded and it's a complete mess. So, in fact, to put a statistic to this observation, the Department of Empowerment of Persons with Disability in India actually analyzed public trains and buses throughout the entire country and deemed that less than 7% of public trains and buses, specifically in Mumbai, were deemed appropriately wheelchair accessible. And by less than 7%, this includes both the stations being accessible as well as the actual trains and buses being accessible. And what we see is less than 7% is really a shocking number, especially due to the reliance of public transport in Mumbai to get around. This seems like a fundamental requirement for non-ambulatory DMD patients and other physical disability patients with with non-ambulation who are wheelchair bound, that they're just not able to access the public transport that is essential for living in a city like Mumbai. So now we can discuss calls for increased accessibility. The fact that there's been an introduction recently in recent years and decades of private third-party agencies that have started to offer more accommodations for individuals who are wheelchair bound. And now these accommodations include wheelchair taxi services and other on-demand mobility services, which are specifically targeted at the demographic of individuals with a physical disability. Now, obviously, given the fact that these are private companies who are doing this for profits, these services are significantly more expensive than standard public transportation. So, unfortunately, this seems to be a luxury that is only afforded to rich families, whereas the common family suffering with a patient from DMD or any sort of physical disability who's wheelchair bound cannot really afford these basic accommodations. So, it seems like accommodations that should be very standard for all individuals with physical disabilities are actually something that only the rich can afford. And we'll circle back to this idea of the socioeconomic disparities, particularly in India for individuals with DMD later on in this presentation. So now let's talk about something positive, some hope for the future. So Prime Minister Modi in 2015 introduced a widespread governmental plan known as the Accessible India Campaign. Now, the Accessible India campaign, obviously, the primary objective of it was to increase accessibility for individuals with physical disabilities in India. Now, the three primary objectives of this Accessible India campaign are the Environmental Sustainability Program. Now, the Environmental Sustainability Program is what I was talking about earlier when I'm discussing parks, schools, public places, libraries, things like this, which are not sustainable for individuals with DMD. So this facet of Modi's Accessible India campaign serves to make schools, public health buildings, and other buildings around India more sustainable for individuals who are wheelchair bound. Now, the next primary objective is the transportation system sustainability. And the fact that this is one of the three objectives of the entire governmental plan once again shows how important the public transport system is for an individual living in a big city in India. And within this objective, what we see is making train and bus stations more accessible, as well as making the actual trains and buses more accessible, which includes enforcing the fact that individuals with disabilities who are riding on a bus or train are actually able to utilize the spaces reserved for them. So which means mitigating overcrowding, as well as informing the public about the fact that they must allow individuals with disabilities to access safe and easy access into the compartments that are reserved for them. Now, the final objective of the Accessible India campaign is the information communication ecosystem accessibility subdomain. This is less important for DMD since DMD is primarily a musculoskeletal illness with physical manifestations, but this is more for individuals who are blind or deaf, as well as things like interpretive services, adding captions to movies and to television programs, and allowing for communication with individuals who cannot communicate normally. But in terms of DMD, the two that are especially relevant are the environmental sustainability subdomain and the transportation system sustainability. And overall, what this shows is that accessibility has been recognized by the Indian government as a prime issue within the country. So this offers us good hope for the future that not only have these issues been isolated and identified, that there have been steps and documentation laid out with specific objectives and actionables that are looking to increase accessibility, which would really help DMD patients in India. So the key takeaways from this section is that first, there seems to be a lack of accessibility. We established the fact that lack of accessibility seems to be a general concern in India across various domains and sectors of personal, professional, and public life. Moreover, socioeconomic disparities also influence who is really able to afford the luxuries of accommodative services. And this seems quite remiss since accommodative services should actually be fundamental human rights rather than luxuries only afforded to individuals with the money for it. But however, we discussed at the very end a glimmer of hope for the country, which is the Accessible India campaign, which provides hope for the future in the sense that both environment and public transportation accommodations are at the forefront of Indian governmental funding, concern, and objectives in the next few decades and maybe even centuries.
All right, so now let's look more into the challenges in accessing healthcare services, specifically in the context of insurance coverage in India. So data shows that only 37.2% of the total population in India is covered by any type of health insurance. And unfortunately, this means that a significant portion of individuals with DMD may not have access to health insurance coverage. And furthermore, of this population that has health insurance, approximately 78% is covered by public insurance companies. And public insurance schemes in general may not always cover rare diseases like DMD, and this leaves individuals and their families struggling to afford necessary medical services. And on the other hand, private insurance can be more comprehensive, but it's also significantly more expensive. And only a small portion of those with insurance in India have private insurance. So the lack of coverage for DMD services under public insurance schemes can be challenging for families, especially when they're already dealing with the high cost of managing the condition itself. And India also faces high out-of-pocket expenses for healthcare, which can be devastating for families dealing with chronic conditions like DMD. And this has an impact on poverty levels, and studies have shown that these expenses specifically pushed about 7% of the Indian population below the poverty threshold. So for families dealing with DMD, these high out-of-pocket expenses can further worsen their financial burden and potentially impact the quality of care and overall life for individuals with DMD.
So the next aspect of DMD in India that we want to explore are healthcare disparities. And we touched on this topic in the first two topics that we discussed through the introducing the socioeconomic lens of looking at DMD, particularly in India. And this section will talk about another India-specific geographic disparity that exists, which really exacerbates patient care outcomes and disease progressions for individuals with the exact same DMD diagnosis, but with shockingly different outcomes. So first, let's set the stage by talking about the burdening costs of treatment of DMD in India. So Indian researchers are currently discovering integrative treatments for DMD. And by integrative treatments, we mean treatments similar to the multidisciplinary care plan that we discussed in this class extensively. However, this integrative treatment is actually not accessible for all DMD patients and their families. The treatment costs around 2 to 3 crores per year per child, and equating this to the American currency, this would be around $300,000 per year minimum for multidisciplinary treatment for a child with DMD every year. Now, this cost makes it very difficult for families to seek the necessary care for their children, especially if they do not have insurance or if they have insurance that has high out-of-pocket costs or does not cover rare disorders like DMD, which require a very multidisciplinary and complex care strategy. So now let's discuss the geographic disparity that exists that affects DMD disease progression and treatment, specifically in India. And this is the distinction between individuals living in urban areas compared to rural areas. So 72% of India's population, which is a shocking majority, 716 million people effectively, live in rural areas of the country. And now most of the high-end healthcare facilities and resources in India that are able to offer physical therapy, cardiology, respiratory services, and GI appointments are concentrated in urban areas. And through our experience in the class, we learned that all of these multidisciplinary treatments are needed to even halt some of the progression and symptoms of DMD. Now, the fact of the matter is that the majority of Indian population does not even have access to these high-end healthcare facilities because they live in rural areas. So this means that the real cost of DMD actually exceeds the 300,000 USD or the 2 to 3 crore number that we provided in the previous slide. The real cost includes the cost of either transportation, daily or weekly or monthly to these facilities, or even the cost of housing and the cost of living in an urban area if a DMD family decides to move for better access to healthcare facilities. And this actually is quite common of a concern. The fact that a DMD family who needs to attend weekly medical appointments might feel the obligation to move into an urban area just due to logistical convenience. But at the same time, the cost of housing and the cost of living in an urban area is significantly more expensive compared to a rural area. So all in all, this makes care unrealistically and logistically quite impossible. So why are we exploring the socioeconomic lens? So in our class, we started to touch on in the opening weeks how the socioeconomic and cultural factors can affect the DMD patient experience completely for both Darius and Dusty. We saw two individuals with the exact same illness, the exact same diagnosis, have shockingly different lives and outcomes just due to socioeconomic and cultural factors. And in our project, we wanted to circle back to this idea through an examination of the socioeconomic lens of disease in India in particular. Since, as we know, patient experiences and outcomes can vary so dramatically, we wanted to see in a developing country like India, where healthcare insurance is less widespread, where rural populations are the majority, how the socioeconomic factors can actually make DMD that much more difficult to treat or that much more logistically unfeasible. And what we found through our exploration in our research for this project is that in India uniquely, there's a high rural farming population, which does not have access to comprehensive healthcare facilities or therapeutic services like most of us do in the United States. So to conclude this topic of our presentation, I want to provide kind of a comparison between the United States, a developed country, which was the focus of our class, compared to India, which is a developing country, and how DMD differs in these two countries based on a wide variety of factors. So the culmination of our research illustrated some general trends, which is first that the United States has an emphasis on multidisciplinary care for individuals with DMD. This is what we talked about extensively in our course, involving physical therapy, cardiology and respiratory consultations, steroid therapy, psychosocial services, genetic counseling, and other mental health offerings for both patients and families. We also know that in the United States, there is a relatively more widespread health insurance, and availability of public accommodations is more prevalent. Now, compared to India, which was the focus of our research in this project, we realized that the high rural population means that many symptoms of disease progression remain untreated due to logistical or financial burdens. And as we learned about in our class, early diagnosis and early treatment of DMD is absolutely crucial in order to quench symptoms and somewhat alleviate the distress that DMD provides to a young patient. And what we realize is that the rural population does not afford any of these luxuries. They likely do not have early diagnosis, which leads to even more severe symptoms. They likely then cannot treat these severe symptoms. So it spirals out of control really fast, which can explain some of the poor patient care outcomes, especially in rural areas for individuals with DMD in India. Moreover, there's a lack of widespread health insurance. There's high health insurance costs, high out-of-pocket costs, and limited public accommodations across not only the public transportation system, but other walks of life in India, which especially make dealing with DMD, treating DMD, and slowing the disease progression of a patient with DMD especially challenging.
So now let's move into discussing some of the cultural aspects of having DMD specifically in India. So we will be focusing on societal perceptions, educational barriers, and employment opportunities for individuals with disabilities in general. So to start off, let's start by looking into the societal perceptions of disabilities in India. So there was a qualitative research study conducted in 2009 that looked into the attitudes of people towards people with disabilities in India. And this study found that households often believe that a disability is a consequence of sins committed by the disabled individuals or their parents. And this may have roots in religion, as this belief may be an interpretation of the concept of karma, which is ingrained in Hinduism. And this belief can result in poor conclusions about what people with disabilities can participate in. And the communities especially have negative opinions about the abilities of children with disabilities to attend school and also adults with disabilities to have a regular job. So another qualitative study in 2019 looked into the experiences of youth with disabilities in their transition to adulthood. So the researchers interviewed 25 youth and adults with visual, hearing, or other mobility disabilities. And after interpreting the data, researchers concluded that the participants overall shared that they changed how they presented themselves based on how people around them reacted to their disabilities. And this change can possibly be attributed to the stigmatization of disabilities in Indian culture. And the societal perceptions of disabilities in India are deeply rooted in cultural and religious beliefs and often lead to misconceptions and negative attitudes towards people with disabilities. So addressing these attitudes and perceptions through education is crucial for creating a more inclusive and equitable society for people with disabilities in India. So next, let's discuss the educational barriers faced by individuals with disabilities in India. So approximately 1 in 12 households in India has a family member with a disability, and 4 to 8% of the Indian population experiences a disability. So these statistics highlight the widespread impact of disabilities within the population, and unfortunately, many of these individuals lack access to education and employment opportunities. And this lack of access not only limits their personal and professional growth, but also contributes to the perception of societal misconceptions and stigma surrounding disabilities. And addressing these barriers is crucial to creating a more inclusive and equitable society for all individuals, regardless of their abilities. So in India, the general population's illiteracy rate is approximately 35%. And for people with disabilities, this rate is significantly higher at 52%. And this disparity highlights the additional hurdles faced by individuals with disabilities in accessing education. And these hurdles can be attributed to various factors, including physical barriers, lack of specialized educational resources, and also societal attitudes towards disability. And as an example, inaccessible school buildings and transportation can possibly prevent children with disabilities from attending school. And also the lack of trained teachers and adapted curriculum can additionally hinder their learning experience. So to add on to these statistics, children with disabilities are about 5.5 times more likely to be out of school compared to their peers in the general population. So all of these statistics combined emphasize the urgent need for more inclusive and accessible education policies to ensure that all individuals have equal opportunities to learn. So the exclusion of children with disabilities from education not only deprives them of fundamental rights, but in a way also hinders their overall development and future. And research has actually shown that education is not just about acquiring knowledge, but it's also crucial for social integration, independence, and also improved quality of life. And it's really unfortunate to see that so many children with disabilities, including DMD, miss out on these things in India. So here we are seeing the out of school rates for children with disabilities in different Indian states. So for the graph setup for you to orient yourselves, so on the y-axis is the percentage of individuals out of school, and the x-axis has labels for different states in India. So the purple color is showing the group of children with disabilities, and the dark pinkish color is the general population. So we're seeing that across pretty much all Indian states, the children with disabilities have significantly higher value for the percentage of them that are out of school. So now let's turn our attention to employment and economic opportunities. So people with disabilities in India have significantly lower employment rates than the general population. And this gap has been widening over the past 15 years. So the employment rate among the population with disabilities averages to about 60%. And data within 2 states in India have shown that having a disability reduces the likelihood of being employed by over 30% for males, and this value is expected to be much lower for women as well. And here we have a comparison of employment data between the early 1990s, which is on the left side, and the 2001 census data, which is on the right side. So for the graph setup, so the graphs show different areas in India, which you can see on the x-axis, it's labeled, and the y-axis has the percentage of working age population that is employed within each group. So the pink represents the people with disabilities, and purple represents the general population. So on the right side of each graph, the very right bars that you see, this represents the general population, and this combines data collected from all of India. And we see that this purple bar on the right side stays about the same, but the pink bar has decreased by the early 2000s. So we see that from the early 1990s to the early 2000s that the employment rate for the general population has stayed the same, but for people with disabilities, this rate has gone down. And lastly, let's discuss the impact on households. So the combination of low educational attainment, poor employment prospects, and stigma means that people with disabilities and their households are worse off than the average. So there was a survey that was conducted in 2 states in India, and this revealed higher rates of disabilities in poorer households and a lower frequency of 3 meals a day in households with disabled members. So this provides evidence of the lower living standards that are faced by people with disabilities and their families in India. So to kind of summarize, societal perceptions, educational barriers, and employment challenges significantly impact individuals with disabilities in India.
So to conclude, I want to go back and briefly touch on the 4 topics that we discussed about DMD disease progression in India and offer some hope for the future by kind of outlining the potential solutions that we discovered or we theorized could maybe help India in the coming years, decades, and centuries. So the first one is that we discussed is the lack of accessibility. And for the lack of accessibility, what we really talked about is the fact that there is not very many wheelchair accommodations for individuals with a physical disability like DMD in many public places, including throughout the public transportation system. And thereby, when there are accommodations, these are only afforded to individuals who are quite well off. So for this, we believe that the governmental Accessible India campaign is already a very positive solution. It not only shows that this problem is real and has been identified by the government, it also shows a clear framework and the fact that funding will be appropriated across the next few decades to target this issue. So we think that is great hope for the future. In terms of lack of insurance, this seems to be more of a systemic problem with just the way the Indian healthcare system and insurance system operates, the fact that there's very high out-of-pocket costs and the fact that a lot of public insurances do not cover the multidisciplinary and complex care that DMD requires. For this, we think maybe allocating more money into the insurance system or into healthcare and taking away from things that are maybe more wasteful, even within healthcare, can help to rechannel some of the funds and resources towards individuals so that they can have better insurance, so they can afford better medical services. Then we talked about healthcare disparities, which was kind of a culmination of the 2 topics before, and more specifically, the geographical disparity between rural and urban patients. For this, what we think is really a positive solution is introduction of more hospitals and incentivizing maybe the newest generation of medical school graduates and the young doctors to practice in rural areas, which will really help individuals with DMD receive the care that they need close to where they need it. This will help not eliminate, but rather mitigate a lot of the logistical and financial burdens of DMD by offering the care in a location that is convenient to them. This can also help with early diagnosis and other things like offering therapeutic services. And then finally, we talked about the cultural aspects of DMD, how that affects family life, schooling, employment, and other facets of just day-to-day living. And with this, one of the things that we think about that can really help is the fact that since there's such a stigma around maybe physical disability in general and DMD in India, There could be early education offered to children regarding what physical disability is, not necessarily specifically DMD, but just generally what physical and mental disability looks like, why it happens. Maybe teaching the science and the biology behind it is a proper technique for individuals to, and especially at a young age, to learn what the manifestations of these diseases really are and not attribute them to facts like maybe the family who has a DMD patient just committed sins in their past, something like that. So offering early education can help not only in school to mitigate the sort of stigma, it also helps later on in things like employment because a lot of the reasons that DMD individuals cannot work are primarily physical, but a lot of the other reasons are also subconscious discrimination and biases, which can be nipped if we really introduce early education and clear, accessible education regarding mental and physical disability from a young age. With that being said, these are the references that we use throughout our presentation to gather our data, statistics, and other frameworks for disease prevention in India. And with that being said, I would like to thank you guys for listening to our presentation. I hope you guys enjoyed.